Hello, everyone. My name is Moji Saladata. I am a second-year medical student on the Columbus campus, and I have the pleasure of introducing Dr. Edward Betcher. He is the chair and professor of the Department of Obstetrics and Gynecology at Atrium Health in Navicent and Mercer University School of Medicine. He earned his Doctor of Medicine from the University of Mississippi and completed his internship at the University of Tennessee Health Centers in Memphis, followed by a residency in obstetrics and gynecology at Carlin Clinic in Virginia. Board certified by the American Board of Obstetrics and Gynecology, Dr. Betcher also holds a focused practice designation in minimally invasive gynecologic surgery. With over 25 years of experience in both private practice and academic medicine, Dr. Betcher is a pioneer in robotic surgery for gynecology and is proficient in traditional minimally invasive surgical techniques. He is actively engaged in the national minimally invasive gynecologic surgery community, frequently speaking, teaching, and conducting research on innovative treatments for benign gynecologic conditions, including fibroids, ovarian conditions, tubal disease, endometriosis, pelvic pain, and uterine anomalies. His expertise is sought after by healthcare providers for complex benign gynecologic cases, and he serves as an advisor to the pharmacological and medical device industries. In addition to his specialized practice, Dr. Betcher continues to provide comprehensive general obstetric and gynecologic care, supporting women through their pregnancies and addressing their healthcare needs throughout their lives. Dr. Betcher is also dedicated to philanthropy, serving on national and university foundation boards. In his leisure time, he enjoys piloting aircrafts, glassblowing, skiing, and cooking. Dr. Betcher and his wife, Terry, are proud parents of 2 grown daughters, Madison and Ansley. Thank you.
Good morning. We've got a lot to accomplish today, and I have the pleasure of kind of kicking things off and talking a little bit about how we all can come together to meet the healthcare needs for women, not only here in Central Georgia, but the entire state, the entire Southeast region, and even nationally. And part of what I'd like to spend some time discussing with y'all is, what does the maternal health care team need to look like? I think we have a pretty good idea of where it is now, but where can we go from here? And I'm going to try to plant some seeds with y'all about things that you might be able to take back to your community and how we can strengthen the health care for obstetrical patients, and talk a little bit about why we need to look at it beyond just the pregnancy stage of a woman's life. So first of all, I have no disclosures. And of course, we need to have some objectives whenever we're talking about things. So I'm going to just flash those up for a second, but I think we'll cover them well with what we're going to talk about. So let's talk about who should be part of a maternal health care team. We recognize that this is a very important stage in a woman's life. And you heard a lot about me, and I do a lot of benign GYN aspects, but I also, in my leadership role and in my practice, take care of women who are pregnant or thinking about becoming pregnant or after pregnancy. And on top of that, I spent a fairly significant part of my career practicing in a small rural community in Northeast Mississippi. So these issues have been part of my career, even during residency and beyond. So I'm going to make this very simple. Everyone, okay? Right? I'm going to talk a little bit today about a bullseye approach to how we need to look at maternal health care teams. So I'm just going to make it very simple and sweet and say thank you very much for the opportunity to speak in front of you. I think this sums it up right there, and appreciate the opportunity to talk with you. I'm kidding. I think we need to talk about this a little bit further than just that one statement. But really, I'm not kidding. Okay? I think we really have to start looking at this in a much broader palette than we have previously communicated what are members of the obstetrical team. So let's talk a little bit about why we need to approach this in a team format. I think that, we all are passionate about this issue. We all have what we have as perceived roles about what we should be doing as part of this team. But I'm going to try to explain how we can further collaborate to meet the needs of patients and how there needs to be some philosophical changes that we need to look at and that we need to drive and we need to educate folks about. So I have 2 adult daughters, and one of them is very media savvy, and recently she sent this to me. And you know what? It's the case, okay? 51% of the population is female, and they're realizing, and they always have, to be honest with you, but they're now saying enough is enough. When are we going to start taking women's health care more seriously? When is it going to become a national focal point for services? And I think that we're hitting that critical mass. And if we're not going to pay attention to where things are right now and some of the things that we're seeing affecting women's health care and start addressing some of the barriers and, frankly, some of our really poor outcomes, we may be seeing the next revolt in our society. And you know what? I give them every right to have that revolt. Okay? Yes, I am a man, but I recognize from my work within OBGYN that the needs are not being met, and I need to be sharing that message from a male perspective with both male and female peers. So something that I'm working on, and I'm going to ask y'all to do the same. This is not something that's going to make you warm and fuzzy, and right now I'm going to ask you to remove all sharp objects from the table, and we'll have bottles of Prozac available for you when we break. But we do have some pretty disparaging things to talk about, and I'm not going to try to take away from the next speaker who's going to talk more about this, but right now, most rural communities lack obstetrical services, and that number is going to get worse. And there's some pretty alarming statistics about the number of hospitals that may start moving out of obstetrical services in the next decade. And these are some of the reasons why. We've got 25% of hospitals in a 10-year period of time that shut down their obstetrical units and have created these deserts. And we're facing that within my healthcare system right now. We have a hospital that we're doing everything we can to keep from leading to another desert in this state. And patients routinely are now traveling greater than 100 miles for obstetrical care. Maybe not here in Georgia, but in other states. And we're going to probably start seeing that happen more and more across the national landscape. So why is this happening? Well, I think we have to look at a lot of different issues. Number one, what are the resources that we're giving to rural communities and rural hospitals? And why are their outcomes not comparable to other urban centers? And I think that, we have to really drive home that good care should be good care should be good care. And maybe there needs to be certain specialized care in more of a regional format. And my colleague, Dr. Misty Patel, at the end of the day is going to be talking more about that. But at the same point in time, how do we make sure that folks are getting the care they need in their communities and not having to travel to the care? And I think we have to look at the litigious aspects. We have in this state nuclear malpractice judgments, $12 million, $16 million judgments. And that's sending a message that, if you're going to practice in a high-risk environment, be prepared. And some folks are willing to accept that risk, others are not. And we're seeing more and more folks consider that when they make decisions whether or not they're going to enter into OBGYN. And so I think that that's something we have to look at, and hospitals have to weigh in on that. Can their bottom line support being able to make sure that they can cover for the what if? So I think that that's another aspect we have to look at. And then, lifestyle issues. We're seeing changes in the number of physicians that are entering into smaller practices. We're seeing very little expansion of residency opportunities, and that needs to change. And it's expensive to practice medicine, and there's a reason why physicians are moving more towards working for healthcare systems and working for other entities besides just throwing up their shingle in a smaller community. So this is Georgia. We have a lot of counties that are red and orange here. And although we like orange here at Mercer, this is not one of the cases where orange is good. But I think we have to realize that we have a lot of pockets here that are not getting the OB care that their communities need. And, when we look at criteria, these are some of the criteria that are assigned to some of these categories. And you're looking at, a lot of communities where patients do not have access to health insurance, and that's a factor. And you're looking at a lot of communities where there's not enough providers. And you're looking at a lot of hospitals that are having problems providing obstetrical services. So it's the perfect storm. It's coming together, and we've got to figure out a way not only to ride out the storm, but how to move past it. So March of Dimes, a lot of y'all are familiar with, publishes an annual report, and this is kind of what we're seeing on a national landscape. 32.9, almost 33 per 100,000 women are not doing well, are not surviving their pregnancy. And we're seeing some pretty significant, differences among race. But it's getting worse. It's not getting better. And we have to look at what is the overall health care of women and their health status before they even consider pregnancy. And, everybody, is thinking about, hey, I want to get pregnant. My friend got pregnant. She came home and had this wonderful baby. Shouldn't I? But if you have issues related to hypertension, diabetes, obesity, your outcome may not be the same as your friend who does not have those issues. And how are we educating folks about these conditions and the effects that they have on their pregnancy is a big factor that we need to consider. So this talks about our preterm birth grade. We're failing, okay? I will tell you nationally there was no A's, okay? In the South, we're not alone. Mississippi, Louisiana, Alabama, Georgia, we all received F's this last year, okay? And you're like, well, aren't we talking about maternal issues? Yes, we are. But a lot of patients that have high-risk maternal issues have to deliver prematurely. And so that is a factor that is driving this rate up. And so we need to take that into consideration and look at this as, basically a review of how did we do? How many preterm births did we prevent versus how many did we have? And what were the reasons for these preterm births? More disparaging news, unfortunately. We have a lot of vulnerability here in Georgia. And we have to look at it beyond just reproductive health issues. I think, one of the biggest factors that is gaining national attention is the number of folks that are having mental health issues. And let's face it, nobody goes home with a newborn and says, I feel the best I've ever felt in my life. You add sleep deprivation, the stress of having another newborn. And a friend of mine who practices here in Macon, Dr. Addie Jones, has a great saying. She says, kids for the first 2 years are suicidal, and then they're homicidal after that. So, you're coming home with a newborn that you're doing everything you can to keep alive, and you're trying to recover from a major health event. Yeah, no wonder folks are having issues with postpartum depression. The question is, why are more women not? Let's be honest. So we have to look at those, and social economic factors and environmental factors. These all add up to higher rates of vulnerability in our population. And then we have to look at not only the rates nationally, but our rates are not better. Why are they not better? And I think we need to continue to drill into that, and we're going to continue talking about some of those factors. But we also have problems with adequate access to prenatal care. And we're going to talk about how we here in the United States are different than maybe some of our European colleagues, and why their outcomes may be different than ours. So let's just agree. There may be somebody here that disagrees with me. The team we have in place is not having the impact that's needed, okay? I jokingly say the only thing consistent in medicine is change. So how can we change to have the impact that we need to have to tackle these issues? So let's talk about the team we have. And I want you to think about this as a bullseye, okay? Here's the center of your bullseye, okay? But this is not the entire target. This is the smallest part of the target, okay? So current models, patients come to healthcare, okay? They're driven to, come to the care, not the care come to the patient. And I think that's something that needs to change. And we're looking at that. And we have some really good programs that are developing and starting to make that happen. But we still have not hit that fulcrum, and the seesaw has tipped. We think about antepartum or prenatal care as being, just the physician or the advanced provider, such as nurse practitioners, PAs, things like that. But this care is centered on the fact that it starts when that little line on the urine pregnancy test turns positive. And we probably need to look at it beyond just, when folks actually turn to obstetrical care because of that. And, we've got a very limited window. Typically it's, prenatal care, coming in, having a baby, and then going home. And by the way, we'll see you again in 6 weeks. And we're going to talk about why that might need to change. And then, after that, we'll see you back once a year. Doesn't matter if you've got 3 comorbidities or if you are young, healthy, and doing everything right. That's kind of what insurers will pay for. And we have to look at, some changes for that if we're going to have, some societal changes in how we provide care for women. And then, if you have a high-risk pregnancy, you may go for evaluation and make sure everything's okay with the baby. And the good news is a lot of maternal fetal medicine specialists are looking at, let's talk about the mom. Let's talk about if mama ain't doing well, nobody's doing well. And I think that that's one of the things that we have in place right now. Most offices, most clinics have got support staff. You've got your ultrasonographer, you've got your lab folks, you've got your techs, and you may have a nurse or someone that helps with making sure that the history is appropriate and that your questions are going to be answered, and you have some education. Some programs include your dietitian, your access to WIC. Others do not. Social services, but that's mainly geared on if there's a need. Not everybody should be assessed, and everybody needs to be evaluated, and resources need to be offered to all. And if you're lucky, you have a family that's going to support you during your pregnancy. Unfortunately, not everybody does. Not everybody has a pregnancy that is a positive thing in their life, that they were not planning on getting pregnant, or as I prefer, oh, by the way, when I talk with some patients about undesired pregnancies. But then we also have to look at certain communities have support, others do not. Certain faith-based organizations make this a priority, others do not. And so we need to make sure that those aspects are in place before we can move to the next ring. So during, pregnancy, you come in, you have your baby, you have your OBGYN or your primary care provider or your midwife, and, you have a team, and hopefully you have anesthesia with you, and, you have support services, and then, this is where the pediatrician comes into play. And then, after you have the baby, you go home. Yo-yo. You're on your own, okay? And that's something that I think is one of the biggest things that we need to look at changing, is how are we setting folks up for success after they have this life event? And so I think that, we have to recognize that a lot of folks do have some support. Maybe some have more than others. But the next time you're going in to make sure you're okay is 6 weeks after delivery. And insurers and other programs are not going to pay for you to come in and see somebody before that 6-week period of time on a routine basis, okay? So why is that? Well, it's supposed to be a signal that you're making your transition back to just being you and not just being pregnant, but still it's not meeting the needs. And let's look at it. I mean, 2/3 of all maternal deaths occur in the postpartum period, okay? This is where a lot of times we see folks succumb to heart disease, mental health issues, suicide. We see a lot of folks that leave the hospital doing worse than when they came in. And this is where I think we do have a big impact as a maternal health care team to make a difference. And, it's sad. 80% of maternal deaths are felt to be preventable if we had paid more attention and controlled hypertension better, if we had worked with somebody who is struggling with their mental health needs and made sure that they had more resources and support. These are all things that are deemed as opportunities that we missed. And so I think we have to, take that into account, is that, we're doing better about in-hospital events, and there's a lot of focus, and thankfully there is, on how we can prevent those events that occur, right at the time of delivery. But I think now it's time for us to expand that to both prenatal and postnatal times of lives. Well, it doesn't get any better. We've talked about, dying from pregnancy, but let's talk about the fact that there's a lot of women that exit pregnancy with more health issues than they've had before. And that number is going up dramatically. And so how can we maybe take this as a catalyst, pregnancy, and turn it into an opportunity to improve health, for women based on this one event, that they're suddenly now responsible for themselves and they have a child. How do we make sure that they're still able to take care of that child as they grow up? So this is how things look across the world. Our maternal morbidity rate is higher than if you added up the first 5 right there, okay? Norway, 0, okay? That's not to say that they didn't have any deaths, but 0 per 100,000. So what are they doing right that we're not? What are they doing to make this happen, and how can we pay better attention to that? I think some of the things you see is that in a lot of European countries, they're more consolidated, but they also put more emphasis on women's health care, and they make sure that there are adequate numbers of providers in communities. So I think that that's one aspect that we can look at. Although we have government service programs for healthcare, they're nowhere near what is provided to women during pregnancy, especially in Scandinavia. Folks go in, they have a baby. The only thing they pay for is their food. In some societies, that's it. And then, let's be honest, we are in a model of healthcare where we focus more on, treating the condition instead of preventing it. That's a model that has been found to be ineffective, and we are changing, but maybe not changing fast enough to more of a preventative care model. And a lot of these countries, you have extended time off after having a baby. Anywhere from 14 to 86 weeks. Here in the U.S., you're lucky if you get 6. And some employers will offer a little bit more than that. And then one of the biggest factors is in a lot of these countries, somebody is coming to the house and they're making sure you're okay. And they're making sure that you're getting the needs that your needs are being met. They're making sure that, hey, you're not decompensating with your health at sacrifice for your child. So I think that these are some things that we can definitely take away from their successes and maybe apply to a model here. So let's talk about the team that we aspire. There's your core, okay? So what can we put around this core to make sure that we're hitting the target, okay? Let's expand the target from this big to this big. And so let's talk about starting from the beginning, even before somebody decides that they're going to have a pregnancy or that they're at a stage of life where that is a predominant factor. We have to realize that 18%, and some statistics have this even higher, of women have health issues before that line turns positive on their pregnancy test. And why are we limiting prenatal care to just OBGYN or women's health? Why are we not expanding this and looking at pregnancy across an entire life and not just a small phase of life? And I think there are some things that we can look at, and that is including these discussions with women before they decide to get pregnant, optimizing their health care and their conditions before they do get pregnant. And we have to realize that it's a big stressor on a body. It's a real big stressor. And if somebody's marginal going in, their outcomes are not going to be better coming out of pregnancy. And so I think we need to start thinking about this even before we get to that stage. And I think that that part of that is in my world as an academician who teaches medical students and residents. I try to focus not on just the OB aspects, but I would love to think that everybody is going to go into med school and become an OBGYN. Sorry, Dean Sumner, I would like to think that's going to happen, but folks have different callings and different passions, but I have a responsibility, and my department has a responsibility to discuss with them how this is an important part of life that needs to be led up to. And so I think we need to do a better job with that. We need to look at mental health issues better before folks decide to take that big leap. How are they doing? Have they got the resources in place to be able to deal with the stresses of pregnancy and afterwards? And then, one of the things I thought was really innovative in Scandinavian society, if you are having certain health issues, you get a coach who keeps you accountable, that encourages you and helps you get your health optimized in those societies. And that's really something that we could look at in a lot of our rural communities as ways of having folks that can really support folks that are going through this journey. And then, one of the biggest things is how well are we educating folks that if you have these healthcare issues, you have a higher risk pregnancy, those need to be optimized. And teaching that, when folks are entering into the reproductive stages of life. So these are some of the things I think we can look at. We need to move the care from, where it is to where the patients are. And I think that we are in a really good position to make some really big impacts in our rural communities with this model. How can we, instead of making folks come to the mountain, how do we move the mountain to the folks? And I think that, we are seeing some really good ideas. Doulas. There's a lot of focus with doulas during labor and delivery and prenatal, but can we expand this role to even be preconceptual and even postpartum? And there's some postpartum doulas out there now. So these are, folks that can really advise and support. Community coaches who are willing to go out and, I've been there, I've done that. I got the t-shirt, let me show you a picture of my family, and can share with folks that are pregnant and afterwards. These are things that, can up your game as you're transitioning from having this baby to raising this child. There are certain programs that are really good. Centering. Centering allows a group of women to come together for their prenatal care. And not only do they have the opportunity to get their prenatal care, they also have opportunities for education, and they also have opportunities to develop a peer group. And a lot of obstetrical centering groups move on to pediatric centering groups. So it's a continuum, and I think it's a really good concept that we could look at for bundling obstetrical cares in communities and providing folks with a support group. Technology today is more innovative than ever, but I can tell you right now, I'm not the expert in this area. Why are we not engaging some of our biggest IT gurus in Silicon Valley to help develop models that will work for easier access to virtual care? This is a really great resource that is improving healthcare in a lot of specialties, and we're starting to see how we can apply that in OB. But this is something that I think we could really look at is nurse call centers. In most Scandinavian countries, when you deliver, you're given a toll-free number to call 24/7, 365 if you're having any issues. Or if you have questions. And this is something I think we can expand on. And then, there's always new technologies and new ideas. There's a new app every week. How can we, or every day, or maybe every hour, could be even more frequent than that, but how can we develop those aspects better and make them more accessible? And there's folks out there that's what they focus on, and we should be engaging them. And then how are we doing as far as coordinating care for patients? Who's our air traffic controller? Who's making sure that everybody's getting to the airport in a safe landing? So these are some things I think we should look at. There is a whole industry in our country geared towards logistics. I can tell you right now, don't ask me to figure out how to get patients from 20 different communities to our high-risk OB clinic, besides saying, you drive yourself. It doesn't work, but there are whole companies that do nothing but think about these things. FedEx, UPS, other entities. Why are we not engaging them to help us with these solutions. And this applies more than just transportation. How does this help us get the technology we need to patients? And, how do we make sure that folks are not having food insecurities by making sure that those resources in place? And one of the biggest barriers for folks saying that they are not coming for prenatal care is because they don't have child care for their other kids for that appointment where they need to focus and concentrate on themselves. And then, some of the Scandinavian countries, you come home with this nice big box of supplies. And this box actually is your bassinet. And why are we not providing those kind of services to patients? So we've got opportunities. Now, the big question that y'all are scratching your head is, how are we going to pay for those opportunities? And I'm going to leave that to smarter people in the room than myself. But I do think that it is an investment, and we have to think about not just the immediate return on that investment, but long term. How much money are we spending on the outcomes that are poor? For lifelong support, continuing on generational problems that are occurring. I think we have to look at it as long ball, not look at it necessarily as just here and now, but where's it going to lead and impact us 10 and 20 years from now? So other aspects we can look at, I really think that these patients that we all see are left, just dangling after delivery. So can we implement, home visit nursing opportunities and make this something that is covered for third-party payers? And, can we look at expansion of social services? And one of the biggest things that I think is, how do we have patients receive prenatal care more frequently than just once? And how do we expand it beyond the 6 weeks? 6 weeks is when physiologically a body returns back to normal. But that doesn't mean that somebody is doing well after having a baby. And so we need to look at not only expanding it maybe beyond 6 weeks to maybe a year, 2 years. Very pleased to see some expansion of Medicaid beyond just 6 weeks. And, I think that's a great opportunity for us to start some healthcare maintenance issues for patients and getting them started. But how can we go from there to even better opportunities? And then, of course, just because someone has a baby doesn't mean that they know how to take care of this child. I jokingly say it doesn't go baby placenta owner's manual. You got to make it up as you go. But sometimes you're just sitting there trying to figure out now what, much less, how you can make good decisions for raising a child. So, the outer ring, okay? How do we engage those that are not focusing on pregnancy to realize that this is one of the biggest societal concerns that we have? Like I said, if mama's not doing well, nobody's doing well. And how do we change folks' thoughts about that, and that this is a critical point in time where somebody needs to have resources pushed to them? We're seeing so many political and legislative endeavors that are impacting women's health right now. I jokingly say that T is the most dangerous letter in the alphabet. It's the difference between can and can't do. And we're hearing a lot of can'ts from Washington, from Atlanta, from local communities. When can we start shifting that to what we can do for women's health? And when can we start making bigger impacts for women's health instead of diluting or restricting it? And I think that's going to take a lot of challenging discussions, to be honest. Not everybody feels the same way or thinks the same way. but when can we find some common ground to say that when folks are going through their maternal stage of life, that this is something that is a priority, not a exception to the society itself. And I think there's a lot of PR aspects that can be improved. How many of y'all remember the free ad that was on television with the guy sitting over the frying pan with eggs and talking about, this is your brain on drugs. Got it? Boy, that had a big impact. We see the same thing with cigarette smoking. Why are we not putting together media campaigns like that along these issues? And, social media is a double-edged sword. We hear a lot about how it's not making things better, but how can it make it better? So I'm going to wrap up by saying, what does this expanded team look like? Well, again, everyone. And we need to engage more and more folks to be involved in this team. And we need to encourage folks to prioritize these healthcare needs. And I know I'm preaching to the choir. Everybody here feels the same way. But I'm hoping that this has shared with you some ideas and some thoughts that you can take back to wherever you are to start looking at making some of these changes and expanding the teams that you're part of, and how to interact better with the teammates that you have available to you and develop new ones. So on a lighter note, I'm going to just wrap up there, and I'm going to open the floor to any questions or comments, concerns, critiques. Yes?
Remember that chart around deaths per 100,000 by each country?
Uh-huh.
Do you think that could possibly be impacted by simply the population of the country? Do you think that has any major effect on?
So the question is, talking about maternal morbidity mortality rates in Europe versus here, and the question was, is it impacted by the population of those countries? Yes, it is. When you're a smaller country, you probably can focus more on certain issues, but there are other times where I think that you can expand that scale to bigger areas, and we need to look at how we can make that happen. I saw somebody else raise a hand someplace. I'll do my best to repeat it.
I've been doing OB since '83, been in this room, maternal child, pediatrics. It's been the same with OB as far as this problem we have with the OB down in the deserts. I'm just a little peon, but I always try to mention it. It's a money thing. Why can't we get those big old team buildings like some of the other places do, and they can get their silos and stuff, contract with the teaching hospitals,
Mm-hmm.
for the people who need all that experience of residents, and then you got the main doctors like y'all over them, and they
Mhm.
go out to these places instead of those people having to travel. I mean, I know it's a money thing because that's just a simple idea, but it's a money thing.
Yeah, I think it is, and I think it's a priority issue too. I think it was Zig Ziglar that said that there's nothing cold and hard about cash. When it's in your pocket, it's warm and fuzzy. And I think that, when do we decide, on multiple levels that this is a priority and not just, we hope it turns out well. I think there's a lot of folks out there that recognize the current environment with the poor maternal mortality and morbidity issues, and they say it's a shame. We should do something about it. But I'm not seeing as many folks step up saying, this is the resources that we need to devote to it, and this is what we need to do to make it happen. And it doesn't have to be, it's kind of like the movie Moneyball. It's home runs are great. Home runs we all celebrate. We think they're phenomenal. But what wins games is getting on base and then getting on base again and getting on base again. And how do we maybe look at that model where we start developing more resources now and we invest at this level and then the following year this level and so and so. So we may have to look at a different strategy to make sure that this is not just a one-time opportunity to improve, but over decades. Like you said, you've been doing this since '83, and the same issues that existed in '83 are here in 2024. Yes, ma'am.
I think part of the undoing is years ago, back in the 30s, 40s, we had the model that you're describing. There weren't as many specialists, so you could take the specialists off the table. But you had midwives, you had nurses, you had doulas that would go out to the homes and do exactly what you're talking about. The problem was when more specialists came in on the picture and the government decided, oh, that's a better model, then the perception and the discussion around the table was a midwife is not good for you. You need to go to an OB. And I'm not trying to knock doctors. I'm just saying this is history, and what we're trying to do is bring back the history that worked. Granted, we had a lot less people, so it worked better with fewer. But it's undoing those learned lessons and learned perceptions.
Yeah, I think that, what can we learn from where we've been historically? How can we not end up solving one problem and creating another? This is what history teaches us. And I think one of the big factors I would say is instead of an or model that was being looked at then, how do we turn this into an and model? How do we find this collaborative environment for these relationships to occur? So, yes, ma'am.
To build on what you're saying about where we were previously with the midwifery model, one person that I feel was calling out was the legislators. And that's because so much of what we do is regulated by state legislature. And so just working in the past with the state legislature to expand nurse practitioner and nurse midwifery roles, we have to take that into consideration. Your slide with the comparison to other countries, I've seen similar information from the Commonwealth Fund. And one thing that they spoke a lot about was a lot of these countries have an overwhelming more greater workforce of midwives than they do obstetricians. And so that's something to consider as well, is expanding how many more midwives are brought to the table.
Yeah, by the way, that slide was taken from the Commonwealth Fund report. So as far as things go, I think that, like I said before, I said it about medicine. The only thing consistent in medicine is change. Well, that is also a motto within healthcare. So how do we take where we are now and how do we improve upon it? And how do we build these teams and these teams work well together? Again, I think that, we hear a lot that comes out of on national media and beyond talking about, can'ts within women's healthcare. How do we change that to cans in women's healthcare?
So the fertility rate in the United States is dropping precipitously, as it is in other countries. And it seems to me that this would be a national, in our own national interest, to decrease maternal morbidity and poor outcomes. And I think you're right. There's a huge need to educate folks in terms of what reproduction is and isn't, and what factors influence successful reproductive outcomes. what suggestions do you have for folks to be able to do that?
Boy, if I had another hour. No, I mean, you bring up a very good point. Birth rates are the lowest since they've been since 1979. Women are making more decisions about their reproduction options than ever before, and more are waiting to postpone that, and that's a factor. And there's questions about are there other issues in our environment that are affecting that too. We also look at the fact that there's been some positive things too, that the unintended teen pregnancy rate has dropped. So that's another factor that we think of maybe as more of a positive than a negative. But more and more folks are making better, I wouldn't say better, I would say more conscious decisions about what the size of their family is going to be like, and they're planning it. And so these are all factors that we have to look at where healthcare is now, and how more and more patients are having these comorbidities that I've been talking about. The number of women in their teens and 20s that have hypertension and diabetes already, along with other health conditions. And, those things used to be, I guess, the best way of putting it is so poorly controlled that folks didn't conceive. And now there's better control and they are able to conceive, but it doesn't mean they're going to have a good outcome. So how do we continue to move from, okay, you can get pregnant, to how we can make sure that you have a good outcome with pregnancy? And I think these are all things that we have to look at. And we're seeing some really interesting things in our society. And the fact is that the birth rate that we currently have cannot support the population that is maturing. So how do we make sure that we take care of everybody? Those are some tough decisions being made in Washington and Atlanta. But like I said, I think we have to promote this more as a long-term strategy than an immediate crisis strategy. I think it has to be both. It has to be, we need attention to the problem now, but we also need to make sure that we don't end up in this same situation down the road. Yes, ma'am.
About educating medical students, what would you add to our curriculum?
I'm sorry, Dr. Baker, I didn't quite hear you.
Speak up. About education of medical students, what would you add to our current curriculum for reproduction, module, or any other module?
Yeah, I think that it's not just me, but I think those of us that are educators in women's health are realizing that the strategy that we need to look at is not just teaching, how to deliver a baby, but how to make sure that someone is going to have a good outcome, no matter what area of medicine a medical student goes into. And that's one of the things when I have the medical students rotating with me that I say is that, not every one of you is going to go into OBGYN, but there's not a single specialty out there that I'm aware of that you're not going to have patients that have women's health needs. And how do we change that landscape to make sure that we encourage those that take care of patients, pediatricians and primary care, and even subspecialists and specialists are focusing on those unique aspects for women's health and making sure that the patients are doing well no matter where they are in life. All right, I've been doing a lot of preaching. I'm going to step back and let somebody else have the pulpit for a while. I appreciate the opportunity to talk with y'all, and feel free to catch me during the breaks if you have any other questions you'd like to ask in a different forum. Thank you.